is, we use this concept called primary palliative care. We're hoping that not just nurses, but nurse practitioners and physicians, community physicians, family practice, and oncology can understand and know just the very basic parts of palliative care so that they can deliver primary palliative care to all of their patients regardless. And then there's those extreme, more difficult cases that work in the field can add in and have support in those areas. So focus in a little bit on palliative care and oncology, and then some tips, and then the last one is just more of a discussion about what you all can do in your specific situations, which obviously they're all different, to implement and further that influence of palliative care for your patients in your clinics. So this comes from the Oncology Nursing Society, a statement that says oncology nurses are critical participants in the delivery of palliative care, which I think is fantastic. I say that, and this is why I'm pretty intimidated. You all do the vast majority of the care for the patients, physicians, and again, I like to make fun of physicians too, because we are focused. We have a specific role, and this is our job, and we do that, and that's why the nurses that are so supportive come, and they actually kind of clean up after us sometimes and fix things, and it helps us so much. And so this is part of the reason why the topic today is to help us understand specifically the basics of palliative care so that you can explain it, so that you can introduce it, and you can feel comfortable bringing up those topics with those patients so that they can have access to this specialty. So this is the I put this in almost every single palliative care lecture that I give because it is I don't know if you can see it. Sometimes it doesn't show up, the bigger ring. Are you able to see it from that angle? So the statement is that all hospice is palliative care, but not all palliative care is hospice. So that's something to think about and remember, is just that hospice is that 6 months of life or less by definition of Medicare. Palliative care is years, 3 to 5 or more years prior to someone's death or prior to their qualification for hospice, and encompasses a broad range of diagnoses and patients that need this kind of service. So hopefully this makes sense. It's just kind of an image that's on the Center to Advance Palliative Care's website that just describes it in a nutshell. It's very simple. This next one is also a standard that I put in just about everyone, mainly because, like we talked about, we're trying to educate everyone on the basic principles of palliative care. And this one describes the dark blue being disease-directed therapies, chemotherapy, other curative treatments. The light blue is palliative care. Diagnosis is on the left, and time. So over toward the right would be where hospice is involved, and you enroll in that hospice service. And it's just interesting if you can imagine the care that happens for some of your patients. Sometimes they get really ill and they have a spike in symptoms, or they have some other incident or hospitalization or something that occurs, and they need a little bit more help from a symptom management or a supportive care standpoint, and that's when the palliative care team is involved. And then sometimes it backs off and they're just focused on their chemotherapy and their treatment, and they're able to just focus on their curative treatment and back and forth. And that's why it's some of these diagrams are a straight line like that. Some of them, this is my favorite one because it goes up and down. That's how palliative care should be viewed, is we're involved when we need to be, and then when we don't need to be, we can back off and not be as involved and continue to be a support for your patients and the team. So let's see. You probably hopefully everyone is familiar with what the interdisciplinary team is. So palliative care and hospice are very similar in their constitution of how they deliver care. This is the thing that you're describing that is lacking. Most of the time you make a referral and you don't get all of this, and A lot of that is because many of these ancillary services are just not reimbursed to in the home, or not reimbursed to very well, and it takes a large center like the Seattle Cancer Care Alliance to have multiple people just there because they need to be there. So a lot of it's system driven, and how much available, and how highly value, how much the system values the input and the support of palliative care. So it's but this is the typical group that would surround a patient and their family to be able to help deliver comprehensive palliative care. Hopefully that makes sense. It's helpful. So let's. The other one that I like to describe, and this comes from some articles on the National Quality Forums for what palliative care is supposed to deliver. So they start out with the structure and process, and that relates to that circular diagram with all of the team that's involved, all the team members that can be involved to help support patients. The physical aspects of care are basically their symptoms, their treatments, and everything that goes along with their medical care. One of the things I like to put into this bucket, number 2 and number 3, is relates to survivorship, which is what we call disease trajectory education, and it's helping patients see, okay, I've been diagnosed with this. It has associated with it a specific prognosis, a specific set of treatments, and a specific risk of certain hospitalizations for different reasons, and you go through and be able to educate the patients based on that. The psychological, psychiatric aspects of their care. Interestingly, the vast majority of what we do is actually this, and unfortunately, because of payment models and systems, we don't have a psychologist or a psychiatrist very well involved in patients' care. And the survivorship that you were describing, that's a social worker that has good psychiatric training can help avoid a lot of those issues when they're involved with survivorship, and help set someone up very well for survivorship. It's very important. The social aspects, of course, insurance coverage, care at home, all of those things. Spiritual, religious, existential aspects is, as it's described, most palliative care teams have a chaplain that digs into all of these areas that patients can suffer. Cultural is very important. In my job in the inpatient palliative care service, it's very common in Boise. There houses a lot of refugees and a lot of patients that come from different cultural backgrounds, and everyone handles stress. Everyone handles those kind of events differently, and so being aware of and catering to those cultural differences is extremely important to helping them, the patients and families, get through their difficult times. Care of the patient at end of life, which is, there's some great lectures, and obviously hospice fits right into that domain. And then ethical legal, and this is where advanced care planning and living will and post-form and all of those issues of who is the surrogate decision maker when that patient's admitted to the hospital in a coma or things like that. Those are extremely important. I would say more than 50% of the time in my work on the inpatient palliative care service is spent trying to determine who should make the decisions and helping the families understand and agree that that is the right way to proceed. It's all under that ethical and legal aspects of care. So those are some simple, basic concepts from palliative care that hopefully makes a little bit more sense to you all. So moving along, we'll dial in a little bit more to the specifics of oncology. This is the study I was referencing in 2010. Many of you may have already read this or seen this or could explain it better than I can. But this was basically the landmark study that helped push palliative care further along from the standpoint of it being a medical subspecialty. And Jennifer Timmel, who is the one that led this group, but basically they studied simple intervention of typical treatment for non-small cell lung cancer plus typical treatment plus palliative care referral at diagnosis. And they showed a couple of key things. Obviously, hopefully, not always like we've already described, but hopefully quality of life is better with the supportive care teams that come in with palliative care. It all depends on the system and what access you have to a comprehensive team. And then the reduction in depressive symptoms, I think, was impressive. A lot of it was related to what we described from a survivorship standpoint. It's preemptively talking to patients about what they may experience in the future. That term is disease trajectory education, as well as anticipatory grief, is one of the things that we focus on a lot to help teach patients, hey, beware. This is what you will experience, and these are likely incidents that will occur, and it helps a substantial amount in that regard. The last one is kind of the key to all of it.